Dear Chairman, thank you for the invitation to present at the EBC 2021. The title of my presentation is Principle of IVL, Current IVL Data and Indications in Calcified Coronary Lesions. Regarding the stent-oriented goals after PCI, the efficient stent delivery is essential. Thus, we have learned also from intravascular imaging that a good mechanical results can be achieved when MSA is greater than 80 or 90% with an absolute MSA greater than 5.5 square millimeter if dissection is not present, plaque burden at the edge, and malposition should also be avoided. Well, from several studies, we know that an adequate stent implantation can reduce clinical events and of course symptoms on the one hand side, but also often results during lesion preparation, which is mandatory to achieve such a good results in procedural complication. So balloons have an insufficient force to crack calcium, often results in barotrauma or balloon rupture. Also, atheroablative strategy are also limited by a wire bias, only potential resulting in slow flow situation or even perforation. Taking this into account, intravascular lithotripsy has been introduced, especially in lesions where calcium angle is more than 180 degrees and calcium thickness is more than 0.5 millimeter. Additional consideration using IVL are vessel with a lesion and a large residual lumen more than 2 millimeters, or ortho-osteal lesions, or of course bifurcations. The intravascular lithotripsy comes with a balloon catheter and a generator. The generator produces energy which are applied by the emitters in the balloon catheter. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create rapidly expanding bubbles that generates the sonic pressure waves and then collapses within a few microseconds. When wave impact the calcium at nearly 50 atmosphere, they create a series of microfractures and then makes the vessel more compliant. Here you can see the effect of lithotripsy either in OCT, you can see the microfractures, or in IVUS. In the latest data coming from the CAD III trial, IVL showed a high safety endpoint. The primary endpoint, which was freedom from MATE within 30 days, was observed in 92.2%. The lower confidence boundary of 89.9% meets the performance goal. Here you can see the clinical endpoints, which were rather low. However, there was a high success rate after treatment with IVL. Finally, I want to show a clinical case which shows a severe calcified lesion, which is nicely demonstrated in the intravascular imaging, which was OCT in the right coronary artery. And IVL treatment was then applied here in the severe calcified lesion, which results in a high compliance of the former stenosed vessel. So the IVL treatment leads to better vessel compliance after creating the microfractures, resulting in inadequate stent expansion. So therefore, I like to conclude: adequate stent deployment following after optimal lesion preparation is mandatory for better clinical outcomes. Conventional strategies in severe coronary calcification might be insufficient. and therefore intravascular lithotripsy offers an alternative treatment to ensure optimal stent deployment, thereby demonstrating efficacy and safety. Thank you very much.